Go.
Okay. Hi, Roger. Thank you for allowing us to present here. So my company is called BreakBio, and what we do is treat people with cancer with the aim of at least curing some. So many people try and prevent some of the cancer growing for a period of time. Our aim is to try and kill all the cancer so it doesn't recur. And the way we do that is we analyze the challenge with cancer is different in the patient, in one patient, is different across the tumor. There are many branches. And if you kill half the branches, the other half can grow. And so what you have to try and do is kill all of them at the same time. If you don't kill all of them at the same time, you have to switch drugs to a second line drug or a third line drug. So what we do is we analyze the cancer cells, try and understand all the different branches, and then we manufacture drugs for that patient. So it's personalized and customized manufacture drugs for that one patient to try and at least for some people cure them. I'll show you some slides now just to illustrate what we're talking about and the science behind that. So the company name, as you can see here, is BreakBio, and we're treating or curing solid cancers. BreakBio creates new T cells, especially against non-mutated targets. Similar in some ways to Keytruda, which helps T cells, we create new T cells. And I just check on the time here, make sure we're not going too long. So we use an AI platform to identify 30 targets per patient. And then it's called a vaccine. It doesn't prevent cancer, it treats cancer, but the vaccine creates the T cells. And we have one approved IND from the FDA. So we had a trial approved. We're ready to start trials. We hope to inject the first patient this year. The trial was approved for colorectal, but we've changed our strategy to orphan drug designations, which are faster to approval because there's fewer patients and it's lower cost to get approval. We want to get approval so patients across the country can use this. Trials would be at top hospitals, for example, MD Anderson. As I mentioned, the problem with cancer, infectious disease is you breathe out, the other person catches it. It's the same in both patients. Cancer is growing within the patient and it's changing and changing. It's growing every 1 or 2 days. So a year later, you might have 100 generations. The cancer may be 100 generations descended from the original cancer cell. And so it's all different in one patient, all different in another patient. Our solution is similar to Keytruda. Keytruda is a great drug, very successful, and it works for many, many cancers, many people. And the way Keytruda works is it doesn't target the cancer directly, but it helps the T cells. And because it helps the T cells, it can work on the T cells in many different types of patients. So while Keytruda helps existing T cells, our drug creates new T cells. And Keytruda works for many cancers if they are mutations, if they have mutations. Our drugs work for many cancers even if there are no mutations, and I'll explain why in a little bit. We will also use Keytruda, and so it'll improve Keytruda outcomes because as well as creating new T cells, we want to help T cells. And we'll also work in cancers with low mutations because we are not targeting only mutations. So the way this is done is we take a biopsy, we take some tissues, some cancer cells from that patient. We have to build the drugs for that patient. So we have to get a little sample, just like it's sent for genetic sequencing or foundation medicine. We analyze the cancer cells with this thing called mass spec per patient, and it's mass spec of the MHC-bound peptides. Our AI platform then chooses the targets, including non-mutated targets, and we manufacture 30 peptides. We inject these 30 peptides with adjuvants. Adjuvants are helpers. They teach the body that this is something bad. You need to fight it to create T cells. The body then creates T cells. So if you go back to the previous slide, while Keytruda helps existing T cells, we choose the targets and we get the body to create new T cells, but the right T cells for that patient's cancer cells, to kill that patient's cancer cells, and ideally to kill all the different types of cancer cells. That's why we have so many targets. So going back, we're similar to an immunotherapy. We're Keytruda. We create new T cells. We do a biopsy, we analyze, we choose targets, and we manufacture these 30 targets for one patient. The other patient gets next, a different patient gets different targets. We inject them, and the body creates T cells itself. So half of what we do is AI drug discovery. Very interesting software, very complicated, great technology available for this, but we run the software per patient. And we're already injecting patients, already treating patients. Half of what we do is immunotherapy, very similar to Keytruda. It's the biggest, most successful drug in cancer, and it's the biggest drug in the world. and we create new T cells. Our software platform finds non-mutated targets, including dark genome targets, which are very interesting. And our aim is to find targets across all branches. So what's unique to BreakBio is we do this AI training per patient. We train our AI model with the mass spec of MHC-bound peptides. We find mutation-related targets, but the body already creates T cells against neoantigens, these mutation-related targets. And we know that the body creates T cells because Keytruda already helps them. The competitors do only this, and they don't have the mass spec data. But we also find these kinds of targets, and most of our targets are these ones. These are overexpressed non-mutated targets. And the body doesn't naturally create T cells. So when we create T cells, these are all new to the body, all new to the tumor. So we expect higher efficacy, and we've seen that in early compassionate use patients. So that's our software platform, how we choose the targets. A bit more detail on software platform, how we try and find all these little branches, all the branches of cancer. We put the data in, it analyzes and clusters the targets. We choose 30 targets. We believe that our vaccine, peptide vaccine, are better than mRNA vaccines that BioNTech uses in cancer. For example, BioNTech has an mRNA vaccine. BioNTech also has a peptide vaccine. They acquired a peptide company, which is a strong indicator if you're a very successful mRNA company and you buy a peptide vaccine company, that for cancer you need peptide vaccines. These are only used in cancer. Every other treatment they do uses mRNA. But it creates more T cells. It creates T cells against 50% of targets by their own data, while their own data shows their mRNA vaccine created T cells against only 11% of targets, which is why we do a peptide vaccine. It is better for creating T cells, and T cells are what's required in cancer. For COVID, for other things, you create antibodies. But for cancer, you need T cells, and peptides are better. We've treated a patient, for example, with GBM, glioblastoma, very difficult disease, and the treatment halted disease progression. The doctor writing this letter said the results were nothing short of astounding. And GBM, if chemo no longer works, as in this patient, the cancer grows very, very fast. It can, people say it grows like wildfire or like a mushroom cloud exploding in the brain. It fills up everything. Yet here, for months and months, we stopped the growth, and you can see the tumors were getting smaller, which is great. And so that's a very good example of why targeting our many, many targets, including non-mutated targets, has much better efficacy. Competitors have not been able to make the tumors go down with this kind of treatment. Another one is a uterine leiomyosarcoma patient, and they had a resection in February 2024, then chemo. They have a lot of capital, and they have a lot of scientists, teams of scientists. They chose our drug, which is called BreakVax. We designed one version of BreakVax, started it, designed an improved version, continued with that. They expected a 60-70% chance of recurrence, and the patient had no recurrence, which is a very good indication, also some early data. So this is great and very exciting that we can analyze cancer, build drugs per patient, and seems to be working. The next step is a randomized controlled trial, get the randomized controlled trial to prove exactly how well it works. Now, how does BreakBio compare to Moderna's melanoma cancers and BioNTech's pancreatic vaccine? These are also personalized, but they target only mutated targets, the very simple stuff. They don't invest much in the software. And they do big cancers, and they try to prevent recurrence. They don't try and treat people with existing cancer. We treat people with existing cancer. We, as well as mutated targets, we do overexpressed non-mutated targets and some novel targets. I won't go into detail just yet, but very interesting too. We do AI training. We train our platform with data from this patient. They train their platform with data from past patients. And in cancer, that's no good. In fact, it's probably worse to train your system with the wrong patient's data because their cancer is different. So you're actually probably degrading your efficacy. And, we prime more T cells, 50% plus. We expect probably more like 65%. Our manufacturing is proven. Cost is lower. We create T cells because it's not mutated. Peptide vaccines better. And we're a vertical company. These are horizontal players. They do a little bit of everything, which means they're not so good at any of them. And we focus only on cancer. It's a big market and a very complicated and very different. And we focus on the AI ML platform. team is myself. I used to run a tech company. My wife got cancer, sadly, started learning about it, and now I think we can solve the problem. And David and Kim and Brian, I'm just going to ask you just to say hello quickly and just briefly explain where you were beforehand to give a bit of context, please. David, you want to go ahead?
Sure. I'm David Hawk. I'm the CTO at BreakBio, and I most recently was at the MD Anderson Cancer Center, where I was running the proteomics facility there based on mainly mass spectrometry, and did a lot of MHC peptide analysis there, which was very much like what we do here, and for the same purposes.
Great. Thank you, David.
Mhm.
Brian?
Yep. So I'm Brian Parker. I'm the head of bioinformatics for BreakBio. My background is in sequence analysis, pipeline development, and neoantigen pipeline development. My previously, I've worked at a company called Gene-Centric Therapeutics, where that's really where I built a lot of my skills in the pipeline development area. Currently, I do some work at the University of North Carolina at Chapel Hill, kind of in that same vein, but primarily I handle sort of the intersection of biology and software at BreakBio.
Great. Thank you. So that is the summary of BreakBio. We build drugs, analyze the cancer in each patient, and build the drugs for each patient.